That's good to see so many of them are joining fast and quickly. Yeah.
Good evening, everyone. Welcome to iFocus Online, Lecture 255, Squint and Pediatric Ophthalmology, Session 42. Today we have Dr. V. Rajesh Prabu from Sankara Eye Hospital, Coimbatore, for the open quiz for all on Kahoot app. It gives me immense privilege to introduce Dr. V. Rajesh Prabu, sir. He completed his MBBS in Kiplock Medical College, Chennai, DNB Ophthalmology from Arvind Eye Hospital, Coimbatore, Fellowship in Pediatric Ophthalmology and Strabismus from Arvind Eye Hospital, Coimbatore, Observership at Children's Eye Hospital, Boston, and Ulstein Eye Institute, UCLA in 2012. He was consultant at Arvind Eye Hospital, Coimbatore till 2014. Currently heads the Department of Pediatric Ophthalmology and Strabismus at Sankara Eye Hospital, Coimbatore. May I now request Rolika to...
Yeah. Rajesh, so would you like to say a few words before while I switch on the quiz platform?
Yeah, sure. Thanks. Thank you so much, Venkateshwar, for giving us this opportunity. And I made this quiz purposely with very basic questions, which will be a sort of revision for whatever the 38 classes happened last few months. So this will be refreshing this thing for them to recap whatever they have learned over 3 months' time. So it will be very simple question answer sessions. I think we'll expect a good participation from the audience.
Right, sir. So now I will just be briefing you all a little bit while I share the screen. So is my screen visible? The audio?
Yes, please go ahead.
Okay, so for those who are joining, you can join on Zoom or on directly the Kahoot app. You can either download Kahoot app or you can even go on to kahoot.it. The game pin that is displaying on top, that is 66674, is your game pin. You can even use the scanner for the scanner ID, right? So the questions will keep displaying over here. For your ease, you can open the system connect to the Zoom platform, as well as open it on your phone so that you can answer and see the questions at the same time. It's as per your convenience. This we'll start the quiz at least after 5 to 8 minutes, so we can have more people joining in. So take your time and join in. And I'll keep briefing you all while you're joining, so it's easy. You do not need to be actively on Zoom platform, and I request everybody to rename your name as your phone number so that it's convenient. That will be better. If it's possible, you can still do that so that we can connect with you. And the winners eventually will be taken up on the Zoom platform. Now comes the interesting part. What are the prizes, which everyone has been asking me, and I have the answer for you. So the first prize will be bagging 10,000 rupees. The second prize will be bagging 5,000, and the third prize will be 3,000 rupees. And the first 10 winners will get certificates as well. Those who are joining on Zoom, I request you to please keep yourself on mute, otherwise it unnecessarily shall hinder with the question display. Okay, so you can keep your audio and your video off so that it's easy for you. Okay, that's great. Everybody's joining with the phone numbers as well. Wonderful. Take your time. We have this port active for you to log in till next 5 to 3 minutes. So Rajesh sir would like to explain the questions as and when we go, so that, and sir has very meticulously framed the questions based on the previous classes. So you must appreciate sir's effort for that. And after every question, sir will be briefing you about the answer, and a leaderboard will be popping up. Now, the interesting part is also that When you answer quickly and correctly, you score higher. And if you answer correctly but late, you still get scored. But if you answer incorrectly, you don't get scored. So be wise and prompt as well.
It's the fastest finger that works in Kahoot. So faster you are, the better it is.
Yes.
But answer only after the time down starts. Countdown timer starts.
I think the time duration for answering is 20 seconds.
20 seconds.
Yeah. I will be displaying the introduction slide once again once we start the quiz.
Correct.
Yeah.
The competition is going to be really tough. So many are participating.
Please keep yourself on mute. So, what's the counter coming? Just a second.
Around
34.
20 in
34.
24.
34.
3 more minutes. Yeah.
So the Zoom joiners, please keep yourself on mute. That will be really kind. Otherwise, it causes a lot of disturbance. Whether you join on Zoom or not, you will not have a delay. You will still answer at the same time. So don't worry about it. Sunilji, could you please make Subhash admin as well so that we can keep muting if anybody joins? Yeah, I'm doing that, but please, that would be great help.
Do you know how to do that? Subhash knows, right?
Yeah, Subhash, we just have to click on the mute button, so that's all, right?
Yes, Rohit.
Yeah, 38 have joined, so I expect more to join in so that it's like real hardcore competition.
Okay.
In the meanwhile, I would like to say that, sorry, sir.
No, give until 8:10 exactly. We can start at 8:10.
Sure, sir. We start at 8:10.
Yeah.
Right. Meanwhile, I would like to say thank you so much, Rajesh sir. You have very, you have coordinated very well and sent the slides out perfectly arranged for us to be on Kahoot platform.
Thank you so much.
Thank you so much.
Good.
43 have joined. So the ones who've joined, why don't you guys circulate the game pin to your friends on your WhatsApp groups so that you can easily have more number of people join them.
Some are dropping out.
Actually, I think they're joining in with the phone number, so that's why.
I think they're changing the name to number.
Even if you join with your name, it's fine. It's okay. Somebody has joined with like 11-digit phone number. I don't know how that works, but okay. So again, like we are left with 1 minute before we start the quiz, and I'll still again brief you. Also, one more thing, you can join at any time, even if we start the quiz. We're not going to lock the joining room. So even if you miss 1 or 2 questions, trust me, it can be a game changer. So it's not a big deal. You can still ask your friends to join in. So again, I'm just mentioning to you all that the questions will remain for 20 seconds. And so if you don't mind, I can start off the quiz and show the introductory slide.
Yeah, sure. 1 more minute.
1 minute. Exactly at 8:10 you can start.
Yeah, I'm just showing the intro slide.
You can't do that without starting it.
Okay.
Okay.
So the instructions are that the quiz will be played on Kahoot, and there will be 20 questions, actually 25, right?
25.
And yeah, so each question will have 4 possible answers for you, and every question has 20 seconds, and once the time lapses, the last selected answer will be considered final. So make sure that you do not in fact, I feel that once you click on the answer, it doesn't change, and if none of the options are selected, then it is automatically taken as the wrong answer, right?
Awesome.
Yeah, so please just make sure that you're prompt. So fastest fingers first with correct answers is the key. And after every question, there will be a leaderboard, and Rajesh sir will also be discussing the answers with you all.
I think you can start now.
I think you can start.
Okay, fine. So would you like to take the questions, or how would you like me to narrate the questions?
He'll have to.
I'll narrate. You just play the
Right,
slide.
sir.
I'll narrate.
I'll just play the slide.
Sure. So welcome to this quiz program. So we'll start with the basic vision assessment. So all of the following tests require use of special glasses, except I think this was the second question, right? Rolika, you have to go to the first question.
So that's the sequencer, don't worry, sir.
Okay, fine. So all of the following tests require use of special glasses, except option A, TNO, option B, Titmus, Randolph, and Frisbee test. Can you wait for 20 seconds, or can we start the explanation?
28 have
You're done. Yeah. I am surprised to see still a few wrong answers in this question. So TNO is a test which requires special red-green glasses. It works under the principle of anaglyphy. And Titmus plate test needs a special glasses in the form of Polaroid glasses. And Randolph stereogram is also another test which uses a red-green glasses. Frisbee and Lang test are the two stereotype test, which is doesn't require any special glasses, which can be done with the naked eye. 28 has given right answer. Can you see the leaderboard? But I think BJ is leading.
Okay, we have a sort of a tie on the first position as of now. Okay, sir, should I move on to the next question, sir?
Yeah, we'll go to the next question.
Okay.
Okay. Sensory anomalies associated with the immature visual system. Please read the question carefully. It is immature visual system. Include all except amblyopia, ARC, suppression, and diplopia. Yes, that's a very good answer. So sometimes you might get confused with the ARC, but the ARC is one of the sensory adaptation in the immature visual system. Most of the adaptation after the visual system has matured will have a diplopia. Suppression and amblyopia are the other sensory adaptation which happens with the immature visual system. Go to the leaderboard. There's a close marks between the first 4 candidates. So we'll go to the next question, Rolika. This is a very simple question. Floating saccades into the field of action of the muscles are suggestive of paratic muscle, palsied muscle, restrictive strabismus, or a slip muscle. mixed answers, and 19 have answered as paratic and 20 have answered as slip muscle. This is a very classical exam question any squint specialist wanted to ask from the candidates if they kept a sixth nerve palsy as the exam case. So floating saccades is always very classical of a palsy, complete nerve palsy. All other conditions mentioned here, paratic muscles, restrictive strabismus, and slip muscles have reduced saccadic velocity. They don't have a floating saccades. I thought everyone will click this answer, but unfortunately, many have gone wrong in this. So please remember, floating saccades is the terminology which is classically described for a complete nerve palsy.
Right, sir.
There will be some rearrangement of the marks now, I think. Yes, right. There are new entrants into the top 4 now.
So Nishita has...
Please remember, 1 or 2 questions going wrong, you'll have a complete rearrangement of your position. So please be very careful before answering.
Right. So moving on to the next question, sir.
Yeah. So tests to measure the AC by A ratio include all except heterophoria method, gradient method, fixation disparity method, and Scooby-Burian test. Yes, many of them have gone very correctly. Scooby-Burian test is the test which is used for a patch test, which we normally do for the intermittent exotropia case. So all other tests are typically will be done only to measure the AC by A ratio. There are 4 tests available for AC by A ratio. Commonly done test clinically is the heterophoria and gradient method. Please read the Rosenbaum textbook where there are 4 methods have been described, at least for examination point of view. You should be knowing the names of all the 4 tests. But the commonly learned clinical tests are heterophoria and gradient method. Okay, we'll go to the leaderboard.
So some more reshuffling. So 9559 is back on the leaderboard with prompt answering and challenging Nishita.
And 3 are in almost close. 3342, 3330, and 3300.
Yeah.
Good luck for the next question.
Yeah, and the highlight is that the next question can change everything. So we'll see how that goes.
Fine. Very easy. All are the treatment options for accommodative esotropia except glasses, surgery, myotics, and bifocals. Perfect. But 26 have answered myotics. I think maybe they are not very sure and they have not read the theory part of accommodative esotropia. Glasses is typical because accommodative esotropia will have a high hypermetropia. So glasses is the first line of management. Bifocals, whenever you have an accommodative esotropia with high AC by ratio, that's what the question which we discussed before, the methods of estimating AC by ratio. When you find to have a high AC by ratio, typically glasses has to be prescribed with the executive bifocals. Myotics is one of the prescribed treatment option for accommodative esotropia. Probably not done much nowadays, but definitely that is one of the line of management. The one drug which they commonly use is the decathoyphate iodide, and there are side effects of those drugs like iris cyst and spasm, everything. So please read the textbook about that. Surgery is not done as the first line of management in accommodative esotropia. Very rarely, when there is a terminology called partially accommodative esotropia, where there is some residual squint even after the glasses are worn for a considerable period of time with full refractive corrections. There is a partial accommodative esotropia. Sometimes surgery is indicated for the residual squint. Please read about myotics, the role of myotics in accommodative esotropia. Yes, we can go to the next.
So 9559 is on fire.
And I think he or she has gone quick answering, I think. So it has elevated the score.
Right, sir. So this fire indicates if they are continuously answering the correct answers, they get on fire.
So we can only see these 5 numbers reshuffling. We want new entrants into these 5. Surgical options for exotropic DRS. Please read each and every letter carefully. Exotropic DRS with upshoots and globe retraction includes all except periosteal fixation of LR, lateral rectus recession with fadenization, Y split of LR, and supramaximal resection of LR. Good, wow. But I'm not very happy with 11, 12, and 10 answers of the other three, because classically a textbook teaching, you know that DRS with upshoots and globe retraction is typically because of the co-contraction of LR and MR during attempted adduction. So you need to release the co-contraction. So all these techniques of Y split of LR, LR recession with Faden, and periosteal fixation of LR is done to relieve the co-contraction. Supramaximal resection. Basically, resection is not a procedure of choice in any of the Duane's retraction syndrome, because for the simple reason that a resection procedure will increase the co-contraction. So when you do a LR resection, it is going to increase the co-contraction and worsen this upshoot and globe retraction. So please, when you go for exams, don't mention anything about resections in a case of a DRS. So this question was particularly asked only to point out that important aspect.
Right, so moving on to the leaderboard, and let's see. Wow, so and also the highest climber is 5939. You have moved up 14 places. That's a good escalation.
That's great.
Right. Okay.
Good. So this is the 8th question. A 5-month-old child has a large angle esotropia with cross fixation. So the least likely diagnosis is infantile esotropia, Mobius syndrome, dense amblyopia, and congenital fibrosis of extraocular muscles. The question is the least likely diagnosis. Please read carefully and then you answer. Perfect. And congenital fibrosis is a part of a diagnosis when you have this condition. Mainly, I wanted to point out the importance is about the cross fixations. Whenever the child has got a cross fixation, it means that the child uses the left eye to see the objects in the right and uses the right eye to look at the objects in the left. So they never have dense amblyopia in these patients. So maybe they might have an abduction restriction because of the cross fixation, but never they have amblyopia. So all other possibilities are there with cross fixation.
Right, so just a disclaimer to all. So one question kind of got missed. So it's going to be 24 questions only. Apologies for that.
The first question, yeah.
Yeah, the first question.
I remember the first question was different. Yeah, it's okay, no problem.
I'm sorry for that, but 24 continue, sir.
99559 is still keeping up.
Absolutely. Score has also maintained a symmetry of the scores. So that's great. We'll go on to the next question.
So this is the 9th question, right? So amblyopia treatment methods include all except occlusion, plus optics, penalization, and binocs. Perfect answer is plus optics, but I don't know why many have answered as binocs, because whenever there is a question about amblyopia treatment, the most recent trends will be the one which is asked in the exams, either in the theory or in the practicals. So binocs is one of the method which is then routinely used nowadays in treating anisometropic amblyopia. So you should be knowing about the recent trends and recent advances in the amblyopia treatment. Plus optics is an instrument which is used to diagnose amblyopia or diagnose refractive error. It is not the instrument which is done to treat amblyopia. And occlusion and penalization is, of course, it's a standard answer anybody should be knowing. I'm really surprised somebody has answered penalization also. Penalization is the one which they use atropine ointment to make the eye blur than the amblyopic eye. So that's one of the methods probably not done very routinely nowadays. That's why I think there is some confusion. Some answer is penalization. Occlusion is gold standard, and you should know about atropine penalization also. You can go to the next question.
Oh, wonderful.
For the first time, I think I'm getting a new entrant in the top two.
Yes, sir. And with a thin margin, sir.
Yeah. So almost 10 questions over. You want to have a break or you can continue?
If
they have any queries, questions or something, is it allowed?
Sorry, sir, I moved on to the question, sir.
Okay, we'll just finish this question. Yeah. A child measures of exotropia of 35 for distance and 15 for near before and after the patch test. So what is the type of squint? True divergence, pseudo divergence, convergence insufficiency, and basic. Perfect. So this is the question which I wanted to put in this slide, because everyone, intermittent exotropia is one of the commonest kept exam case in a case of a practical examination. So you should know the types of intermittent exotropia. Basically, it is of 3 types. Basic, where the near and distance deviation is almost equal or within the 10 prism diopters. The difference shouldn't be more than 10 prism diopters. Or it is convergence insufficiency, where the near deviation is more than the distant deviation by more than 10 prism diopters. And the third terminology is divergence excess, where it is the opposite, where the distance measurement is more than the near measurement by more than 10 prism diopters. Once you see a divergence excess, you have to do a Scrooby-Bury and patch test. You patch one eye for 45 minutes and then again re-measure the squint for distance and near. If it remains the same, it is going to be true divergence excess, or if the value is going to change, again, depending on the value, it is classified as basic or pseudo divergence excess. Okay. So this is very commonly asked question, and I mean, cannot miss this. So that is the purpose of putting this question.
So would you like me to wait or
I mean, like anything, if they want to have a break or something for 30 seconds, or if they have any queries in the previous questions?
So if any of the queries pop up, I will like interrupt.
Maybe they can type in the chat box if they want. If they have any queries or something, you can answer. If they want me to explain again, if any of the answers, then we can always. This is because I have the slides with me. You can explain to them. So okay, we can move. We can move to the leaderboard.
Okay. Okay, sir.
Good. So 6589 is leading.
Okay, just this is for clarification, sir. Some of the ones who have joined on Zoom are asking about where to answer. You can still log in immediately. Log in on kahoot.it, or you can download the Kahoot app. Okay, it's written at the bottom of the screen if you can notice. And the game pin is also mentioned, 80666774. So you join there and you can directly come to the particular question going on. You still have a lot of questions left, so you can bounce up easily.
Yes, they can join even now, even if they don't win prizes, at least they can participate and
yes,
maybe we can give 30 seconds for them to any newcomers to join.
Yes, sir. We can wait for like a few seconds if you would like to join. I think Dr. Priyanka had messaged specifically, so I hope to see you there, Dr. Priyanka. So shall I go on to the next question, sir?
Yes, sure. Yes, the type of squint most commonly associated with golden horse syndrome: Brown, Duane's retraction syndrome, CFEOM, and Mobius syndrome. Most of you would have seen this in clinically. Perfect. That's Duane's retraction syndrome, which is very common association with golden horse syndrome. And then the other syndrome which is commonly associated with Duane's retraction syndrome is the Klippel flail anomaly. So systemic associations of squint is another important, interesting topic which examiners wanted to know. So whenever there is some association of the syndrome with the specific squint, you should be knowing that. Okay. So let us go to the next. Okay,
Nadna has a streak of 3, so bouncing up. Great. Nishita has maintained the position. And
yeah,
so
almost all the slides
yes.
she's in one of the top 5.
Yes, and even 9559. So that's a good thing. You have to maintain your position. That matters a lot. So shall I move on to the next one,
Yes,
sir?
please. So the following picture depicts. Please carefully see the picture. It is a pattern strabismus. Kindly identify whether it is A exo, X exo, B ESO, A ESO. Perfect. A ESO. So you have to see the primary position whether it is a ESO or exo. So here if you see there is a large esotropia. Then look at the up gaze and down gaze. You see a increased convergence in the up gaze and decreased convergence. There's more of a divergence in the down gaze. So it's typically of just alphabet A. So it is a esotropia.
Oh, that's a shuffle.
Nishita is gone out.
Yeah, and 4 players just dropped their answer streak of 4. So,
Perfect.
so you have made very interesting questions clearly. So
I think
going
they are
on
a
with the
little
next.
confused. Okay, we'll go to the 13th question. The patient has got a right hypertropia increasing on left face and right head tilt. So the muscle affected is right SO, right IR, left SO, and left IR. Perfect. And I don't know why there are few wrong answers. The typical examination question, the Belchowski's head tilt test for deriving the isolated vertical or oblique muscle palsy. You should be thoroughly knowing this for your examination point of view. So right hypertropia increasing in the opposite gaze and same tilt is classical of a right SO palsy. Okay. We'll go to the leaderboard. Good.
3 players just hit the answer streak 7. That is wonderful. So 3 players have got it all right. Great. So we'll go on to the next question.
Yeah, so we are in the middle. So which of the following is true regarding dissociated vertical deviation? Rare in patients with congenital esotropia, deviated eye intarts as it elevates, always obeys Herring's law. Red light is always below white light in red filter test. That's a perfect answer. The red light is always below the white light because DVD, the difference between a DVD and a true hypertropia is we don't see the corresponding hypotropia of the other eye. Both eye will be a hyperdeviation. The other name for DVD is called alternate hyperphoria or alternating hypertropia. So whenever the red filter is introduced in penta of one eye, either eye, usually the image will be always below the white light in a red filter test. And the other answers why it is wrong is deviated eye extorts as it elevates. And it is very, very common with congenital esotropia. And as you know, classically, it disobeys the Herring's law.
Right. If any of you have any questions related to the questions that have been covered till now, please feel free to message me or on the chat box. I have one of the questions, sir. Can I ask?
Yes, please go ahead.
Okay. So this is just like in general, that can you explain the surgical options in exotropic DRS with upshoot and globe retraction once again?
Yeah, the surgical, basically the surgical options for a DRS depends on whether it is a ESO DRS or exo DRS. The old classical way of describing DRS as type 1, type 2, type 3 is no longer used as far as management is concerned. So it is more typically classified as an exo DRS or ESO DRS or an ortho DRS. Sometimes you might have a DRS with orthotropia. So ESO-DRS, it's classical. We have to do a MR recession, medial rectus recession, because it is esotropia. And EXO-DRS, we have few options. Only EXO-DRS without any upshoots and globe retraction, we simply recess the lateral rectus. That is what I kept as one of the options. But if there is an EXO-DRS along with the upshoot and or downshoot and globe retraction, means there is a severe co-contraction of LR when there is a attempted adduction of right. That is like when there is attempted adduction, both medial rectus and lateral rectus both simultaneously contract. That is called co-contraction. That is the basis of the severe globe retraction as well as the upshoot. So when there is a severe upshoot, Y split is the classical procedure which we do for the EXO-DRS with upshoots. And when there is a severe co-contraction, we try to just take the effect of lateral rectus. So that is why we do either a Paedon procedure or we fix it periosteally in the lateral orbital rim. So resection, that's what I kept as the wrong answer. Resection is never done, never attempted in the case of EXO-DRS, for the simple reason that it will increase the co-contraction and which will worsen the symptoms. I think
yes,
this is
that explains
clear for whoever that person who has asked the question. I mean, if you have any queries, please go back and read about DRS management. You'll be very clear.
Right, sir. So this is our leaderboard. We have all new names coming up. The older ones, we are missing you all. So please come back again. And the newer ones, most welcome.
And they are a little tired, I think. Maybe you can just have a sip of water and get back. We have another 9 more questions, 10 more questions to answer. Right, remember, sir. First prize is 10,000, second prize is 5,000, and third prize is 3,000. Probably that will boost them up again.
Yeah, and the first 10 will be getting a certificate as well.
Certificate from Santosha. So please, that is a prestigious award. Please go ahead.
Okay. Moving on to the next question.
So let them see the picture. Yes, please see the picture, take some time and answer which is all are true except which is false. Inelastic superior tendon complex, A pattern, downshoot in adduction, and positive FDT, forced adduction test. Perfect. I don't know why they have answered inelastic superior tendon complex. This maybe you can show the media again.
Yes.
Yeah, if you see, there is a elevation restricted in adduction, complete restriction, and there is a minimal restricted elevation in straight up gaze, and elevation in abduction is classically normal. So this is a typical Brown syndrome, which is due to the inelastic superior tendon complex. So a typical pattern which is seen in case of a Brown syndrome is V pattern. If you see, there is a attempted elevation, there is a divergence of eye when compared to the depression. So that is why I put this answer. There is a differential diagnosis for this Brown syndrome is a inferior oblique palsy, because inferior oblique acts as a elevator in adduction position. So the main differentiating feature between a Brown syndrome and inferior oblique palsy is the pattern. So you should appreciate pattern to diagnose it as a Brown syndrome or inferior oblique palsy. So A pattern is classically demonstrated in inferior oblique palsy. B pattern is classically demonstrated in a Brown syndrome. That is the purpose of putting this question. Hope I think you are clear with the answer.
Wow, that is one stagnant leaderboard.
Somebody has touched the 5-digit first time. And Sneha has come into the top 5.
Yes.
Good.
Moving on to the next one.
So 9 more questions, I think. So important etiology of an acute painful pupil involved third nerve palsy includes trauma, tumor, vascular, PCA, aneurysm. In between, I ask a very simple question to boost you up. So I think this everyone should answer. Perfect. 52 have answered posterior communicating artery aneurysm. So please remember, acute painful third nerve palsy classically more chances of getting an aneurysm. So that is why when there is a question on what is the next line of management or what is the investigation of choice, you should be answering as a MRI brain along with the MR angiography, because posterior communicating artery is aneurysm is the one which is associated with the painful third nerve. Suppose if your MRI and MRA is supposed to be normal, then we should think about a Tolosa-Hunt syndrome. That is again presents as acute painful third nerve palsy, but Tolosa-Hunt syndrome is a diagnosis by exclusion. You cannot put Tolosa-Hunt syndrome as your first diagnosis. It is a diagnosis by exclusion after ruling out an aneurysm and all other possible causes of a painful third nerve palsy. Treatment is different because Tolosa-Hunt syndrome is treated with steroids. Acute painful, if it is an aneurysm, it's going to be a surgical management. Perfect. Very good answer. Go to the next one.
Right, sir.
It's probably the fastest would have made in this top 5.
And it is written that
know the answer, but I think the fastest would have come into the top 5.
Right. And also that is because 5601 has had a streak with 10 correct answers in a row. So back to back, when you answer, it automatically takes it intuitively.
Perfect. Double phase 601. Perfect. So, okay, we'll go to the 17th question. So all are muscle sequelae of these conditions shown in this picture, except. So this is the question which I wanted you to read a H chart. So typically they'll ask you in the exam. So please go through the answers and tell me the answer which is false. My God. Equal answers. I don't know. Can you show me the media? Carefully, when you read the H chart, you look for the muscle which is underacting. So here it is the superior oblique. So this is the right superior oblique palsy. So what is the muscle sequelae? Is the first muscle sequelae is the immediate overaction of the ipsilateral antagonist. That is, the antagonist of the superior oblique ipsilateral is the inferior oblique. So this is one of the answers. So right inferior oblique overaction has to happen. The next muscle sequelae is the overaction of the contralateral yoke muscle. So the contralateral yoke muscle to the right SO palsy is the left inferior rectus. So left inferior rectus also overact. The third muscle sequelae is the secondary inhibitional palsy of the antagonist of this muscle. So inferior rectus is overacting. So because of that, the superior rectus of the same eye appears to underact because of the inhibitional palsy. So these three are the typical muscle sequelae which happens after an isolated vertical muscle palsy. So the left one is the right inferior rectus, because right superior oblique palsy, there is nothing to do with the right inferior rectus. So that overaction or underaction will not happen. Perfect. I think most of them I've got, but I think
this was a confusing answer for all.
So maybe some more time they would have answered. Answering in 20 seconds is little task actually.
Yes. Okay.
So
there is a question. Again. Would you like me to ask you?
Yes.
Okay, so the question is that in a pattern strabismus, what should be the difference in primary up and down gaze in terms of PBCT?
Yes. So there are two common patterns which we see clinically is the A and the V pattern. All other patterns, X, Y, lambda are all very, very uncommon patterns to strabismus. So for a patient to be diagnosed as a A pattern, whether it is esotropia or exotropia, the difference between the up gaze and down gaze should be at least minimum of 10 prism diopters. And then for a V pattern, which is very common pattern strabismus, which we see clinically, the difference between up gaze and down gaze should be minimum of more than 15 prism diopters. Please remember this number, 10 for A and 15 for B.
Okay, sir. So shall I move on to the next question then?
Yes, please.
Thank you for answering the question, sir.
So 18th, the characteristics of a congenital nystagmus are all except presence of oscillopsia, absent during sleep, present in all cases, and decreases on convergence. Perfect. And decreasing on convergence is a classical finding of a congenital motor nystagmus. I don't know why 18 answered is decreases on convergence. Present, it is horizontal nystagmus. Present horizontal in all the cases is typical, and it is typically absent during sleep. And oscillopsia is a classical symptom of an acquired nystagmus. Never occurs in a congenital nystagmus. And a congenital motor nystagmus typically decreases on convergence. If you take a pen and take the pen close to the nose, typically the nystagmus disappears. So that is very classical. So oscillopsia is a symptom of an acquired nystagmus, whatever the reasons may be.
Right, so going to the leaderboard.
Yes, K has come up first time, I think.
Yes, and 5601 has maintained it. I wish we actually had asked them to put in their name so that we can address them.
No, that is suspension. No, that is good.
Yeah.
Even we don't know the names. We don't know even whether she or he. So, I mean, it's a good thing.
So the suspense continues. And
Yes.
Aisha is back with an answer streak of 3. So we'll go on to the next question.
Yeah. So we're reaching the 19th one. So Botox, which is very commonly used, I think is more like an oculoplastic question. So acts by preventing release of acetylcholine. It is useful in non-resolving 16th palsy, treatment of choice for blepharospasm, and efficacy remains the same with repeated injections.
Wow.
Perfect.
I'm happy to see this.
Efficacy remains same with repeated injection. It's a wrong answer. The efficacy actually decreases. Is mainly I put it in the point of strabismus point of view, because Botox is one which is commonly used in strabismus as well, particularly when we deal with the 16th palsy management in order to prevent the anterior segment ischemia. So we, instead of touching one muscle, we put Botox in the medial rectus. And the treatment and what is the type of botulinum toxin, all these things are the theory questions which you should be knowing.
Right, sir.
So SK has gone out with the oculoplastic question.
That is right, correct. So 5601 has maintained the leaderboard. That's great. The suspense continues.
Yes, okay. So 20th, yes. So surgical options for the affected muscles. So carefully look at the affected muscles and tell me the surgical options. Except, I think there is no except. I think the answer is except. Surgical options for the affected muscle include except. So Jensen, Haradaito, Hammelshim, and Nishida. Sorry for that mistake. Except.
Okay, sir. So they still knew the answer.
So this, yes. So this is typical 16th. That's a very easy question. So mainly I wanted to put this answer because you should know the surgical options for 16th palsy. You should know the named procedures, because 16th is one of the commonly asked question in theory as well as practical exam. So Jensen is a muscle union procedure where they tie the one half of the lateral rectus with the superior rectus and one half of the other half of the lateral rectus with the inferior rectus, just to maintain the transposition. And Hammelshim is the semi-off tendon transposition of the LR and with the superior rectus and inferior rectus. Nishida is the newer technique which is commonly done nowadays, which is again used for improving the abduction in a 16th palsy. I hope everyone knows that Harada-Ito procedure is the one which is commonly used for a SO palsy, which is 4th nerve palsy, particularly for a bilateral SO palsy, which is nothing to do with your 16th nerve palsy. Perfect.
Right, so this is the leaderboard before the last 5 questions.
The last 4, no? We are ending up with 24.
So 25th, the questions are there till 25, so the first slide got missed, yeah.
Okay, then we can do, if there is a tie at the end of 24th question, we can shoot the 25th question.
Okay, fine. All right, sir. So, however, I would like to put in a question before the last 5 questions, sir. So can you please explain the difference between the true and pseudo divergence excess and the importance of patch test? And how long do we have to patch the eye in our OPD examinations?
Perfect. See, patch test is done to diagnose what type of intermittent exotropia, if there is any difference between the distance and near measurement on first sitting. So as I told you, there is no difference, and the difference is less than 10% diopter. It straight away falls with a basic type of intermittent exotropia. The question arises when there is a distant measurement more than the near measurement by more than 10% diopters, whether it is because of pseudo divergence excess or true divergence excess. And very interestingly, the question is asked because why are we doing this patch test? Why are we differentiating between a pseudo and divergence? Because the treatment differs. If it is a true divergence excess, we have to operate only on the lateral rectus, not on the medial rectus. If it is a pseudo divergence excess, we can operate on either lateral rectus or we can touch the medial rectus also. So classically, patch test is done by patching either of the eye, whichever eye the eye is squinting, either right or left, minimum of 45 minutes to relieve the something called a tenacious proximal fusion. That is the one which is controlling the squint. So the tenacious proximal fusion is abolished after minimum of 45 minutes to 1 hour of patching. The important point after patching, you measure the squint. When you measure the squint, you have to maintain the patient with only one eye. You are not supposed to allow the patient to see with both eyes together. For that, you have to keep the patch or the occluder in one of the eyes always. When you change the prisms, the commonest mistake which happens is, suppose when you want to change the prism from 35 to 40, sometimes accidentally you remove the patch, then the patient sees with both eyes, again the fusion will come. So the purpose of doing a patch test to break the tenacious proximal fusion is lost. So you have to do a squint measurement for near and distance after patching by removing the patch and always keeping the occluder in front of either eye, and never allow the patient to see with both eyes together, never allow the patient to fuse. So after the measurement, when you see the near deviation increases and matching with the distant deviation, then it is called as the pseudo divergence excess, which is very common. True divergence excess is very rare. So that is the point of doing a patch test. Right. I hope answered the question.
Very much in details too, sir. So I hope that explains to all, because it's quite important in the OPD setups, and the postgraduates at least must be able to understand the same.
Yeah.
Yes, sir. Moving on to the 21st question, sir.
Yes, again, identify the affected muscle. So I think you have been taught to read a H chart. Now you have to know how to read a diplopia chart. Left IR, left SO, right IO, and right SR. Perfect. Can you show me the media? So whenever there's a diplopia chart, just look in what the red is in front of right eye or left. This thing here it is mentioned as the green in front of left eye. So you see the green image which is down. That means the left eye is hypertropic. Usually it is a crossed diplopia. So this means that the right eye has got a hypertropia. And the next step is to see where the deviation is maximum. So here you can see the deviation or the separation of images is more in the dextro depression. This is right eye. So dextro depression, it is more. The muscles, the two muscles which act in the dextro depressions are the right inferior rectus or the left superior oblique. So again, it's a left SO, which is going to cause a left hypertropia and more separation of images in the dextroversion. If you see the intorted image also, whenever the eye is extorted, you see the image in the diplopia chart as intorted. So left SO is basically S superiors are all intorted, so the eye will be extorted. So the image in the diplopia chart will be intorted. So this is a typical diplopia chart representation of a superior oblique palsy. Here in this case, it is a left superior oblique. I think many picked up correctly.
Yes, sir. 28 got it right.
Yes.
So let's see what's on the leaderboard.
I think there is some shuffling.
Yes,
good.
SK is back.
And 12,000, there are 4 close in 12,000 range. So yeah, probably you can hit these last 3 questions to win the prize.
Approximately 900 to 800 pointers can be won if you hit the correct answers. So my suggestion here would be like a person who likes to answer on Kahoot, is that now for the next few questions, if you want to hit the top 5, answer fast. Don't care about right or wrong, just answer fast. And 9559 is also back. So
yes. And people who are in the
quickly.
first 3 positions try to maintain their position to get a chance to win the prize.
Absolutely, sir. Shall I move on to the next question?
Yes,
sir?
please. Yes, all of the following are true regarding the picture shown below, except yes. Some question on strabismus surgery. So maybe seen following squint surgery, treated with lubricating eye drops, mostly asymptomatic, needs immediate surgical intervention. I want the false answer. Perfect. This is a classical picture of a Dellen. So whenever there is a loss of integrity of the surface because of the squint procedure, because of the sutures, so sometimes there is a area where there is no hydration happens. So it's a classical Dellen. Dellen is the one which is very, very, very self-resolving on its own by the use of just lubricating drops alone. Doesn't need any immediate surgical intervention.
So that is 41 people answered. I think this is the most correctly answered questions.
Yeah, that is the first question which many of them hit correctly.
Yes, sir. The moment we go out of the squint extremes, everybody lands up answering correctly. Okay, going to the next question, sir. Sorry, the leaderboard. So 9559 understood my concept. You have to hit the right answer immediately.
I think the last 2 questions, right? 2 or 3 more?
Yes, so 3 more.
Okay.
Going on to the 23rd question, sir.
Yes, aberrant regeneration of third nerve can occur in all except trauma, congenital, aneurysms, and vascular. Has answered as congenital third nerve palsy. So, yeah, see, aberrant regeneration is very, very common with trauma as classically described in textbook. It can also occur in a congenital third nerve palsy because definitely I know many will answer as congenital, and it can occur with aneurysms also. Vascular disease, either it is diabetic or a hypertensive mononeuropathy, will never have a aberrant regeneration. So when you come across a vascular disease, recovery is going to be full and spontaneous. So this is the answer. I think that has brought few more into this picture. BJ is, I think he answered the first question correctly and again came back.
Yes, so they know how to maintain it now. So like you have to hit the right answer extremely quickly.
PJ has to answer 1 or 2 questions to make it top 3.
Top 3. So just a quick reminder. So approximately, like if you answer by the end of like last 3 seconds or something, you get 500 score up. And if you're answering in the first few, you get like some 800 score up. So work on it. Yes,
still you have a chance. So 24th question is match the following. Just complete. 6th nerve palsy, modified Nishida, MED, inverse snap, SO palsy, Harada Ito, nystagmus, Kestenbaum, Anderson procedure. This is the very easiest question to answer. Perfect. Can I go back to the media again? So MED, the typical procedure of choice is the NAP procedure, not inverse NAP. I specifically put this question is because being an examiner for the DNB exam for a couple of years, last years, we have seen people who come as examiners very much interested in asking the named surgical procedures. So because a lot of respect has been given to the one who has either found the procedure or modified the procedure. So at least in Squint, you should know there are at least over 6 to 10 named surgical procedures. You should know all the named procedures. Even if you don't know much about the procedure, at least you should know where it is done. So here the wrong answer is an inverse nap. Inverse nap is classically done when there is an inferior rectus entrapment or a inferior rectus palsy following a closed trauma, blowout fracture or something like that. MED, it is basically an elevation problem. So the lateral rectus and medial rectus is transposed to the superior rectus, which is called as a nap procedure, not inverse naps.
Right, so before we go on to the last question and hence celebrations, can I ask you another question that has been asked?
Yeah, please.
So which method is preferred to calculate the AC by ratio in OPD basis?
And gradient. We use normally a gradient method where they calculate after adding a +3 or a -3 lens, we measure the squint that is for near or distance based on whether you use +3 or -3. The measurement before adding the lens and after adding the lens, there's a formula which is commonly used. You have to derive from that value. Gradient and heterophoria, both methods are the most common methods which is used clinically.
Right, so next question again is going to be a similar question as matching the pair. So be fast. And the leaderboard shows any changes?
Almost
it remains the same. Okay,
remains the same.
Fine. All right. You have to jump just a few pointers and let's see how it goes.
As a question on a pediatric cataract, very easy. Just wanted to put this question because all questions are strabismus. So oil droplet cataract, galactosemia, Christmas tree fabris, rosette trauma, sunflower Wilson, which is the wrong answer.
I am sure that this will have the highest.
Perfect. It is typically spoke-shaped cataract. Good. We will see the.
And I'm quite certain that might change the leaderboard. So would you want me to go to the leaderboard directly?
Yeah, I think it's very classical. Rosette, all of you know that it's because of trauma, sunflower, Wilson's, and oil droplet galactosemia. Usually Christmas tree is classically seen in myotonic dystrophy, and Fabry's disease has some spoke-like cataract. So pediatric cataract, when there is a question on pediatric cataract or when there is a case kept as a pediatric cataract, you should know all these different morphological types of cataracts, different syndromes or disease associated with cataract and subluxated lenses. All these are typical exam questions.
Okay, so before we go on to the next slide, let me tell you that the first 5 will be asked to join in. And let's see how that goes. This question was probably a game changer. So on the 3rd position, we have 8765. In the 2nd position, we have 9559. And on the 1st position, we have 5601.
See, so, if they are already logged in the Zoom, I think they can unmute and introduce yourself.
You can send a message to their number, no? On WhatsApp,
right, sir.
Direct.
So I'm doing that, sir.
Yeah.
Yeah.
And you can also show the report so that just take down the number first before you go to next.
Yeah, I've taken the number, sir.
Yeah.
And we're just sending them the Zoom link while it takes some time.
You can see the report and announce the top 10 also then.
Right, sir. So should I click on share podium?
Yeah.
Okay.
You can go to next. Yeah. View full report.
Right, sir. 1 second.
Play new game under that. Yeah, that's it.
It's stop the share screen, I guess. Is it?
Okay, it's okay.
No, it is seen.
It is seen, okay.
I think the report is being...
It's just calculating.
Yeah.
You have to take down the top 10. It will be available offline also. If you can announce, that will be good. $99 players.
99 is good number.
I think this is the highest, sir.
Yeah.
So now I'm clicking on the top 10. These are our top 10.
Yes.
Are all 10 being displayed, sir?
Yeah, all 10
Yes,
are.
yes. It ends with Aisha.
979478855601 is number 1. 9315099559 is number 2. 95523987665 is 3. SK is 4. BJ is 5. 987749402 is 6. 8141290887. Sneha Pandu. Then 984542647 and Ayesha.
So can you guys do one thing? It will be easier and faster if you can send me a message on WhatsApp, and I'll send you the link immediately, because it's going to take time otherwise to share the link with you all. Just send me a message on 8826612008. All 10 of you, just send me, and I am ready with the Zoom link to be shared with all of you.
Repeat the number again.
And those who have already logged in Zoom can introduce yourself. Please unmute and introduce yourself.
Yeah, so I'll repeat 8826612008.
Or 98483040001.
Yes, that too.
Everybody should have that number already, sir.
I
think everybody will already have
Very
that.
well done, Rajesh. Thank you so much.
Thank you, sir. Thank you. I hope I made some justice to your expectations.
Really, really good. I think a lot of people joined in later. We had 44 to start with. Yeah.
Okay, I've got 2 messages. I request everybody to send it again. I'm repeating my number. 8826612008.
The message,
they're all joining it.
Chat box also shows the number, their number.
Yeah, that. Subhash, you can put it on this thing, YouTube and Facebook Live. Later you can delete it.
Yes, sir.
So they have all messaged, sir. Don't worry, they've all messaged.
Okay, fine. All right.
Yeah.
So you can unshare the screen and then we can have them up there.
Just a second, sir.
Yeah. Just remember or take down the top 10. You can take a screenshot.
Done, sir. So I'll just send them all the links, and they're joining quickly.
Anybody who was on Zoom is in top 10?
If you guys were you're on Zoom, just switch on your cam, please.
If you're in top 10.
So I think I've sent the link to all. Aisha has joined. Hi, Aisha. Nice to see you here.
Unmute yourself, Aisha.
Good evening, all.
You can go with the top 3 first and let them introduce.
So I think high concentration of Kerala. Are they good at Squint or good at quiz?
So 6 of you have messaged me. 7 of you have messaged me. Please, others also get back to it. That would be great.
Tabiba, I think you'll have to unmute yourself.
55601. I've shared the link. So get back to it. That would be great.
Tabiba, I think you'll have to unmute yourself.
55601. I've shared the link. If you guys are in the same room, please, it's preferable to sit far apart.
We are eager to know the top 3. So far, no one is introducing themselves.
Nice to see you, Marushka. It's your fellowship, right?
Yes, sir. I've actually joined virtually hospital as a senior resident in Paediatric Ophthalmology.
Nice.
So the first person, sorry, nice continue, please.
Marushka.
Hi, Marushka. How are you?
Hi, sir. Hi. Thank you. So I was ranked 3.
Oh, perfect.
So the first sorry, so the
Who
first
is top
person.
two?
Hi, sir. Thank you. So I was ranked 3.
Oh, perfect.
Dr. Martha, can you just switch off the audio that's playing in the background?
Okay, so first position is backed by Dr. Nisha. Dr. Nisha, could you just introduce yourself?
Hello, good evening, everyone.
Hi, Nisha.
I am third year junior resident from AIMS Rishikesh.
AIMS
Okay,
Rishikesh.
wonderful. So AIMS people are always everywhere, no? Right. And 99559 has not mentioned the name, but could you please introduce yourself here? Okay, so first position is backed by Dr. Who is on the second position? The name, please, 9559. Could you please introduce yourself? Okay, and the third position is by Marushka, as she mentioned. That's great. SK is who? I think that's Shabiba.
Yes. Good evening, all.
Okay.
I am Dr. Shabiba. I am doing fellowship in pediatric ophthalmology at Comtrust Eye Hospital, Calicut.
Congratulations.
Congratulations.
Thank you, sir.
Okay, and BJ happens to be. I've shared the link on message. If Bhaskar and Jay Prasad, sir. Okay.
Yeah. Good evening.
Oh, JP, my God. You're good at Squint, man.
I'm learning at this point of time in life. Basics of Squint from my focus online. Thank you, Santosh, for this wonderful program. It really helps people, irrespective of their age.
No. JP was an oculoplasty specialist. We started off together, actually. Almost.
Yeah.
Hello, sir.
So this is something that has really helped me actually in my practice. Thank you so much, Santosh.
Wonderful.
Yeah.
Thank you so much, sir. And the second position is Dr. Vineet Bhatwani, who has joined now from RPC. JR, which year? Can you introduce yourself, Vineet? Dr. Vineet, you're not audible. Probably your audio is not connected. And 4026 is Dr. Shubham. Dr. Shubham, are you logged in? And Sneha, you are on the 8th position. I'm still waiting for the name of the 7th position. Sneha Pandu has not joined in. And the 7th position is Dr. Venu. Dr. Venu, are you here? You can introduce yourself.
Neha Pandurangan has joined. So
Hi, Sneha. Would you like to introduce yourself? You're on mute, Sneha.
Yeah. Good evening, everyone. I'm Sneha. I'm doing my fellowship in Aravind Eye Hospital, Madurai.
Hi, Sneha. Congrats.
Hi. Thank you, sir.
Vinit?
Hello.
Hi, Swapnil. Tell me.
Hello, ma'am. This is Shubham, ma'am.
Okay.
Actually, I connected from another cell phone, ma'am.
No problem.
Okay.
Yes, ma'am. I'm doing pediatric ophthalmology fellowship in Aravind Eye Hospital, Madurai, ma'am.
Perfect.
Okay. Wonderful. So Madurai is on a roll. I still haven't heard from the 9th position. And 10th is Aisha. Aisha is here. She's the first one to log in. So please introduce yourself.
I'm Sukhija Aisha, third year resident from Government Medical College, Kozhikode, Kerala.
Kozhikode.
7th is Dr. Venu Muralidhar, right?
Yeah.
Right, sir.
Hi, Venu.
Can you all do me a favor? The 4th position, the 5th position, and the 8th position and the 10th position. please send me a message and just forward me all your details so that I can send across the certificates to all of you.
Vinit Balwania has joined just now. So Vinit, can you introduce yourself?
Hi sir, I am Dr. Vinit. I am currently junior resident at RPI Center on Indian Institute of Medical Sciences.
Congrats, Vinit.
And it's good to see so many familiar names and enthusiastic names rather on the quiz platform. It's
and we are seeing
always
winners from all parts of India, no? Right?
Absolutely.
Yes.
Right from top of the country to down south, Madurai.
Rishikesh I think is the northernmost to the southern tip. That's Madurai. So we have everyone.
Good to have Dr. Venu. Venu was my fellow and she has, I think, backed 7th place. Dr. Venu, are you there?
Right. And I can see that Shabiba, you have not answered 3 questions, so probably you could have scored up. I think you joined late, I guess.
Yes.
So that's good enthusiasm too. Yeah, that's great. Yeah, Dr. Venu, would you like to?
Good evening. Yeah, good evening. So I am actually very thrilled to be here because I am an ex-fellow of Dr. Rajesh sir. He is my mentor. It's so nice to see you here.
Thank you, Venu.
I'm sure he's proud of you for answering the questions correctly.
Yeah.
We'll end up fumbling when Santosh sir asks us questions. So great, you're doing great.
Yeah.
So that's about all. Santosh sir, would you like to say something?
I just want to congratulate everyone and thank Rajesh for a wonderful quiz. Thank you, Rolika. Thank you, Subhash, for so nicely coordinating.
Thank you so much, sir. Thank you.
Soon.
Subhash, could you share the slide once?
Yes.
So there's a short announcement that Subhash would like to make for all of you.
Yeah, the much awaited physical eye focus is back. Please do register. It's from February 26th to March 5th and the registrations are open. And please register online at www.miraevents.com.
And before we sign out for the day, let me tell you that the thrilling trauma session is coming up. And that is the next 4 sessions are on ocular trauma, which is a special session arranged for all of you because there are certain questions which remain unanswered because a lot of postgraduate institutes do not get the cases the way they are to be seen. So anyways, the next session is on 18th of November. And that would be the current classification of ophthalmic trauma and clinical evaluation by Dr. Purendra Bhasin sir. And let me tell you, one of my long questions was on trauma. So please be there and we'll help you out figuring out trauma now.
Thank you so much. Good night.
Thank you so much. Thank you, Rolika. Thank you, everyone. Good night.
Thank you so much, sir, for taking out your time and working on it for the past 2 weeks, sir. That is amazing. Thanks a lot, sir.
Thank you so much.
Thank you so much, sir.
Thank you.